I'm Jim Del Rosso, a dermatologist in Las Vegas, Nevada. I've actually been in dermatology since the beginning of my residency for 40 years, originally from Brooklyn, New York, and went to pharmacy school and then meandered out to Ohio for medical school. And have been practicing dermatology first in Ohio, then in Florida, but here in Las Vegas since 1997. So I've been here a while in clinical dermatology and running a research center. So psoriasis is one of those diseases that obviously people, even the lay public, know about psoriasis, and we see many patients that have psoriasis. But what's important is to really break it down into two groups. One is a patient that comes in that has a long-standing history of psoriasis, has been battling it with different treatments because it is a chronic disease that requires continued treatment to keep it under control, or going back to treatment. It goes away, it comes back, but you know it's a semi miracle if it goes away and never comes back, because people carry it pretty much a lot of their life once they develop it, or their whole life. So first is the patient that has that history, and you look at it, and yes, it is psoriasis. It walks like psoriasis, talks like psoriasis, quacks like psoriasis, and you think in the back of your mind, could it be something else? And it's not. So this is a patient with psoriasis, and you have to get all the details and figure out what's the best thing to do right now. What's first line is not what the pharmaceutical company hopes for necessarily, but it's what that patient needs. But then there's another patient that comes in with an eruption on their skin, or that maybe psoriasis, may not be, or they tell you it's psoriasis and it may not be. It's not always that evident. And you have to be a little bit more of a detective, a clinician, and really look for signs of psoriasis. So look at the fingernails, see if there's any pitting. Look in the genital area, because sometimes there's genital psoriasis that they don't even necessarily know is psoriasis, that really tips you off. Look in the scalp. There may be areas of definitive psoriasis in the scalp that they don't necessarily know about. Um, and look in the buttock area and in the gluteal area, because a lot of times there's psoriasis there and people don't even know it. And always making sure you're looking at the hands and feet. And you have to become diagnostic. They might have joint problems, even with limited psoriasis. They may have stiffness. They have difficulty getting going in the morning or after a long drive. Their joints feel stiff. Their hands, a lot of times, the small joints will feel stiff, or they're slow to get out of a car. I mean, sometimes that seems like how we normally feel, but these people will definitely know a difference. But that gets better as they start moving around, and they don't necessarily have joint swelling, but they have psoriatic arthritis, and they may have very limited psoriasis on the skin. But if you see nail pitting, or even scalp psoriasis is more common in people that have psoriatic arthritis. It's very common. So piecing that together and being a detective is sometimes something you have to do with some of these patients.